All right. Well, I see that it is 10:30 Central, and good morning, everybody, and welcome to our Fall 2025 Chai Speaker Series webinar. My name is Tatiana Shippey. I am a professor at the University of Minnesota School of Public Health, and I serve as the Associate Director of Research for the Center for Healthy Aging and Innovation, or CHI, at the University of Minnesota. As far as my physical description goes, I am a white woman with brown hair and green eyes in my 40s. I'm wearing a green shirt with a black sweater. At Chai, we envision a world where every individual can achieve their life goals while aging. We work toward this vision through education, research, policy, and community engagement. The Chai Speaker Series is a biannual event that features leaders in the field presenting on selected topics that are of high interest to our members and community partners. This year, we are focusing on end-of-life care in dementia, which is a topic that was of high interest to our members. This is a topic that affects many of us, both personally and professionally, and continues to be a critical area for improving quality of care. A few logistics about the webinar. Captions are available. You can turn them on or off at any time using the Zoom toolbar. This session is being recorded, and both the recordings and slides will be shared with attendees afterward. Our team is monitoring the chat for any accessibility or technical issues, so feel free to reach out if you need assistance. The general layout of today's webinar is as follows. You will hear a 25-minute presentation by our main speaker, Dr. Abraham Brody. His presentation will be followed by a panel discussion with a group of local experts here in Minnesota. We will have dedicated time at the end to answer any questions you may have. So please add your questions to the Q&A box throughout the presentation. To start, we would like to understand the audience that joins us today in this conversation. So we're going to launch a poll, and I'll just read out the categories in the poll. Which best describes your primary professional role in supporting people at the end of life with a dementia diagnosis? Clinician, researcher, academic, administrator, policymaker, educator or trainer, advocate, nonprofit staff, or other professional. So we'll just give a few seconds to see the results of the poll. Maybe we will wait a little bit more. There we go. Okay, so the categories we see is that most of you are coming from academia, 33%, but we also have 28% of you who are clinicians. We have also a number of folks who are representing other professional organizations, as well as educators, administrators, and advocates. And I appreciate you sharing these categories because knowing where you're coming from, your roles, and your perspectives will be helpful for our speakers and panelists today. And now, without further ado, I am thrilled to introduce Dr. Abraham Brody as our keynote speaker for today. Dr. Brody is a colleague whose work has national and international recognition, and we are very proud and fortunate to host him as our keynote speaker today. Dr. Brody is the Assistant Dean for Transformational Excellence in Aging and the Matthew Mazie Professor of Geriatric Nursing and Professor of Medicine. He leads the Aging at Myers portfolio and founded Aliviado Health to implement high-quality care for individuals with dementia and their care partners. Professor Brody's research focuses on developing and testing technology-leveraged interventions, including precision health and machine learning for older adults with serious illnesses. As an internationally recognized leader, he is the principal investigator for two major NIH-funded consortiums, the NIA Impact Collaboratory, which focuses on dementia care trials, and the Ascent Palliative Care Consortium, which focuses on palliative care science. Welcome, Dr. Brody.
Thank you so much, Dr. Shippey, and it's wonderful to be here with all of you and to have the opportunity to talk about something that I love and give my mission to every day of the week. And so, hoping that, beyond this talk, we'll have a nice discussion with the panel and then conversation with our audience as well around how we support persons living with dementia and their caregivers, care partners, other people that are caring for them at the end of life, from both a practical and clinical aspect, as well as some of the policy gaps. And so that's kind of where I'll be coming from as we talk today, and also as personally as a someone who's had both loved ones who have passed away from dementia with very variable care, as well as a palliative and geriatric nurse practitioner and nurse who's been practicing for over 20 years and chairs the board of a local nonprofit hospice here in New York. So I look forward to talking about all aspects of that and smushing it into 20 to 25 minutes. So we'll see how far we get. This is my obligatory disclosure slide. All statements are personal, do not reflect official US policy or positions of the awards that I'm currently working under. And I thought we'd start with a mission moment because this is something that we can rally around as a clinician, as administrators, as researchers, um, and I'll share a story about a patient that I had been working with. And so this patient was a person living with dementia. They were receiving hospice care in an assisted living facility and was really the inspiration for why I moved from doing large data set research into implementation and how do we care for persons living with dementia at the bedside. This patient had Parkinson's disease dementia. They were living in a memory care assisted living, a very nice one as well. And they were receiving hospice. They were within 6-month prognosis. And one day I received a call from the hospice nurse. And she said, I think that our patient is starting to transition because she's not really talking anymore and looks different. And I had just seen the patient about a week or two beforehand, and I couldn't quite fathom what would cause that change so quickly other than an acute event. And so decided to go out and see the patient. And really what was different was that the patient was no longer talking or verbally expressive and was kind of not really engaging anymore. And when I went out and did a head to toe assessment of the patient, I found that she had developed a pressure injury and that she was in pain. And it wasn't something that she could express, so it became expressed by sitting still and not talking. And so, when we think about this type of opportunity, this is something I've seen over and over in different ways, is that went back, talked to the hospice nurse, explained how pain can express differently in persons living with dementia, received a little bit of Percocet and did some pressure relieving, and she turned back to her personality prior to develop the pressure injury. And so I've seen countless around agitation and giving antipsychotics and how do we assess and do this differently. How do we support caregivers in hospice, palliative care, end of life care? And the fact is that there's a lot that we do because it's what we think is right, but there isn't a lot of evidence that sits behind some of this care. And I'm going to say that not trying to detract from the field, because we know that hospice does an amazing job and that caregivers and the person themselves really appreciate the care that is provided in hospice, in palliative care, in the community. And there's so much more to learn and that we could be doing better. So I'll start with that's our kind of mission moment for today. And just share a little bit about what we do and what we don't know about end of life care in the US among persons living with dementia. So we do know that the rate of nursing home death has declined over the last decade plus. If you actually were to draw this out further, this was from a JAGS article, and you look past COVID-19 pandemic where everyone, there were COVID was spreading through nursing homes. There is now even more intent bias amongst family members about not having their loved ones in a facility, and so this has only continued to downtrend. I just couldn't find a better graph of post-COVID, but there is evidence to show that that exists, and that we are seeing an increase in people dying at home. And that largely coincides with an increase of hospice use for persons living with dementia. So if we think about hospice back in the 80s when it was developed for persons living with cancer, who were approaching the end of life and needed cancer care and wanted to forgo further curative treatments. And today, we stand in a very different place. So if we look at this is the National Hospice and Palliative Care Organization, which is now called something else because they merged with NAC and are called the Alliance for Care at Home. But their data shows that for the vast majority of cases in hospice, 25%, the largest percentage of any serious illness, uh, is amongst persons living with dementia. And if you throw in people with a secondary diagnosis of dementia, meaning that they have a primary terminal illness of heart failure or cancer or something else, that upwards of 50% of people who are currently receiving hospice have cognitive impairment. And yet, hospice has not served as a place where people do research. In academia, we've tended not to get out of our ivory tower, and that has not helped to engage in this setting. And so when we think about this, we now have the largest population of where people die in hospice is persons living with dementia. They have the longest length of stay in hospice of any group as well. So you see at the top there, 159 days compared to 52 in cancer, as the average length of stay. When you look at median, it's even more disparate between dementia and everyone else. And we know that we need to build the evidence in a much better way. And this is both at the policy level for how we provide care in hospice. We know that the current hospice model leads to people getting discharged from hospice because we're not really good at telling when someone is truly within a 6-month terminal diagnosis. So we have high live discharge rates in hospice. And the model may not be the right model in its current regulatory structure, not in terms of its care structure, to provide this care. And ASPE from HHS actually held a session where they brought experts from around the country in August to discuss this very issue. There's supposed to be a report released in January, given the shutdown. I highly doubt that will occur, but will occur at some point after that. But there is a recognition also within the federal government that we need to be thinking about other models or concurrent care or ways to address end-of-life care specifically for persons living with dementia, and reforming the hospice model to address this particular population. We need to also build the evidence around what clinical care we could be providing. So I'll talk about one of the studies that I performed in hospice with 25 hospices, the largest controlled trial that's ever been done in hospice in the United States that we're aware of. And one of the things that we were debating in the beginning amongst the clinical team around how to implement this intervention was, well, do we have any evidence for how we address terminal restlessness or agitation? So someone who's in the last couple of days of life, they're very restless and agitated. How should we be treating them? And we had to come to expert consensus because there's absolutely no evidence for how to do this. And so we created an algorithm based on kind of what practices are currently being performed and what evidence is available in other fields, but there is nothing out there. And that's just one snippet of this. So as we think about this, what I have tried to do over the last 15 years based on that initial clinical experience that I talked about as as our mission moment for the day, and many others beyond that, is to develop a program that's not academic, that is real world, that is how do we help home care, hospice, community-based organizations, long-term care, um, to really advance the care to what we do know for this population. And it's a little tricky because what we do know has to be pulled from other settings and time points in a person living with dementia's trajectory, because most of it is not performed near the end of life. But what we've been able to do and develop is to support clinical teams and caregivers through this program, which is around providing training to frontline clinicians and to executive leadership, providing caregiver education that is at a level and in multilingual capacity to support access for and as a companion to the care that is provided by the clinical team, mentoring to the and technical assistance to the clinical team so that they know where to go and how to ask questions around clinical issues, treatment algorithms and care plans that can help to guide it, because we know when you just give people training, they go back to what they were doing within a matter of 3 months. And so you have to set a whole set of care plan and workforce workflow changes to help constitute real world change. And this is one example. There are other people that are doing other sorts of programs, but what we've found in this program is that it improves clinical knowledge and confidence and attitudes in working with and caring for persons living with dementia, particularly around symptoms and caring for caregivers. And it can also significantly change the type of care that is provided to make it more evidence-based and less reliant on pharmacologic treatments, which aren't as effective in this population. And so what we found in our 25 site trial, which was not a tightly controlled trial, it was helping hospices to implement the program and seeing what they did. And mind you, this was during COVID, so there was some variability because there were huge workforce challenges and not everyone could implement the same way. Was that in agencies that were able to implement this well, and this was done across the United States in multiple different settings, for-profit and nonprofit hospices, small rural hospices and large hospices, that we could reduce antipsychotic use and increase non-pharmacologic or behavioral interventions, such as music therapy or music as a therapy. And I'm using those two very thoughtfully, because people can still perform therapy-like activities with music, but unless it's performed by a skilled and trained music therapist, is not music therapy. And they work in different ways. And so, but as an example, using and shifting resources away from antipsychotic and benzodiazepine use and other potentially inappropriate medications, we're able to provide more person-centered care that actually has knock-on effects on the caregivers as well. Because when you start people on antipsychotics sedate people. So then they start to be sleepier during the day, which means that they're then going to be awake at night, which is going to affect the sleep-wake cycle. And so if you can pull back those antipsychotics, and you're doing things like music, which are engaging people and keeping them awake during the day, you're reducing apathy, you're increasing their quality of life. You're also making it so the caregiver is not having to be up at 2, 3, 4 a.m. every day to address concerns, because the person living with dementia is able to sleep through more of the night. And we've actually done studies separately in nursing homes that have shown similar things, that you can actually completely change sleep, which will impact care for huge troves of an entire unit, by dimming lights, by creating a more quiet environment, by helping the nurses at the nurses station to remember that the louder they are there, it travels throughout the hallway. Simple non-pharmacologic strategies can have huge impacts. And we've seen this where, we walk into a unit before we implement a sleep type intervention, and they it's loud at 11 p.m. at night. And then you have people that are residents that are getting agitated and are not sleeping. And then that means that the CNAs and the LPNs are walking through the hallways, which are then creating more noise and then a knock-on effect, et cetera. And then you come 3 months later after they've implemented, at the same time, the lights are dimmed, it's quiet, et cetera. So and I'm saying this because a lot of our patients are still dying in nursing homes, even on hospice, with dementia. And so we have to think about the environment in nursing homes, the environment in assisted living, the environment in the home, all very differently as we're approaching end of life care. And there's great opportunities around how to do that and support the caregivers, whether they be paired caregiving in a nursing home or family caregivers or professional caregivers in a home-based setting. This is an example of a run chart that one of our hospices showed us at one point, and it's a couple years old now, but I loved it so much that I continue to show it here. It shows how they were implementing this before. They had graphs, but I'm not going to include the graphs here, but it shows what their goals were, which is the most important. Most of the time when we're trying to do quality improvement in these settings, we don't include a numeric goal that is achievable and time bound. So they had a goal for what they wanted to achieve for that year. We helped them set their goals. We looked at what their before data was to be able to set that goal. And then we had them measure on a month-to-month basis using run charts, which are fairly familiar across clinical settings, on how to really monitor their changes. And they were able to reduce antipsychotic rates. They didn't meet goal yet when I took this snippet. They did later on, and continued to decrease. Increased music therapy referrals to the point where they actually were spending so much less on pharmacology, and the nurses and other clinical staff were finding so much good use out of their music therapist that they added another full-time FTE music therapist because they found it to be cost effective and patient and family centered way to do hospice care. Um, they decreased, but not by as much as they had hoped, the amount of people that died in a place that they call home. So that one remained a challenge in terms of not having people transition to other settings, but something that they're working on. And they increased the use of respite care, which is a really underutilized care form in hospice. And so the reason I'm sharing this is because as we think about how to work with hospices, we didn't just choose measures that we thought were important. Antipsychotics was a outcome for the trial, but everything else were centered around what the hospice wanted to achieve. And we did this across our hospices. And so if you're thinking about doing research, quality improvement, trying to change care in hospice, in home care, in nursing homes, you have to think about how you're partnering with the organizations you're working with and making it meaningful to them. And so I'll come back to that at the end, but this is a key point of any of these types of studies is they have to be true partnerships. It can't be an academic coming into a setting and saying, do this. Um, and so our program is now being used across different settings. In Illinois, we have a group of Medicaid case managers that are caring for persons living with dementia that are using our training to help all the case managers with this. Hospice, home care agencies, it's been integrated into a new graduate residency program in nursing homes. And so I'm showing this not because Oliviato is the best thing since sliced bread, but because if we do good research that is engaged in how it's going to help the organizations that care for persons living with dementia as they approach the end of life and partner from the beginning on what the program should look like, we can create programs that long outlast any NIH trial, any grant funding, et cetera, because it becomes a business imperative and something that they want to carry forward. I will say, if you're interested in learning more, please feel free to contact me and we can talk about what our models look like for helping organizations to implement this program. And you can also do creative things. So we now have a 79 site trial that is doing this as well. We also worked with the National Partnership for Healthcare and Hospice Innovation, and our algorithms are all included in their care guides. They were one of our partners in the trial as well. So it's all about how you build a group of partners that can help you impact more than just in your study and maintain sustainability in the real world. Um, and so what we're doing now is one of the things we found is that the emergency department is a place that no one with dementia or their caregiver really wants their loved one to be. And yet, we end up with a large number of persons living with dementia in the emergency room. And so we now have a large 79 site trial running across the United States that's integrating this or redesigning the care in the emergency room or providing community paramedicine to try and address the same issue of for people that go to the ER and go home, can these types of programs, can nurse-led telephonic care that's implementing, person-centered care, can community paramedicine that's addressing care transitions and person and caregiver-focused needs prevent people from coming into the emergency department? Can emergency department providers and nurses talking to each other and talking with the caregiver in a couple of huddles in the ER change the locus of care and make it so that the caregiver is set up to succeed when they leave the ER when coupled with a 72-hour post call, or any one of these combinations of things. So that's what we're looking at now, but it's all based on how do we get out into the community and ensure that people are not in places they don't want to be, that they have the information and resources that they need, that they're not in the emergency room or requiring to go to the hospital, because this is what persons living with dementia and their caregivers overall want, and they don't always have the toolbox to help them get there. And so this is how our team has continued to innovate and change in research that is practice-based research by partnering with different organizations and thinking about the challenges and working on the fly when something isn't working in these real-world initiatives. Um, and then another interesting thing that came from all of this is we ended up developing a mobile app for our hospices because they were having trouble in some cases inserting certain assessments that we were doing into their workflow because their EHRs were old or they didn't have access to change things. And so they asked for a point of care tool, and we created a point of care tool for them so that they could do, for instance, an NPIQ, which is a behavioral symptom assessment, or a modified caregiver strain index in the home or in the nursing home with the patient and the family member present or the caregiver present at the point of care. And then they could get guided on how to then address a patient and family's needs. And what they told us was, why aren't you doing this with the caregivers directly as well? Why can't caregivers self-manage things? And so we've started developing a program around helping caregivers to directly assess and treat their own symptoms with non-pharmacologic interventions. So we do an NPIQ within the app. We then ask them to prioritize what their concerns are, and then we help them develop non-pharmacologic care plans and remind them to carry them out on a daily basis. Still a work in progress. It's an early trial. But one of the things, that's come up recently, I know it's everywhere, is AI. But AI needs to have a purpose and it needs to be accurate. And one of the things we've learned, and this is for both clinicians and caregivers, is what symptom do we treat first if multiple symptoms are present? And you can go by, clinician judgment, you can go by caregiver, what's important to them. But in the end, that may not be the right answer because it might be that one symptom is causing another, or one symptom is more likely to lead to decline at a faster rate. And so we've actually embedded AI into the system to nudge but not tell caregivers, we suggest X. We suggest X is the primary problem that is going to most likely lead to more functional and cognitive decline if it's not treated. And we train this on a nationwide, well-characterized data set from the Alzheimer's Disease Research Centers to do this. And so we're testing this now. It's in a small pilot phase with funding from one of the NIA's AI centers. But it's about, and the reason I'm sharing this is because how do you use what you're learning and listening to your partners to drive where you go next from a study standpoint? And we used a community advisory board of caregivers from diverse communities to help us, people who live in rural areas and in urban areas, and others characteristics to help us think this through. Bereaved caregivers, current caregivers, et cetera. One other thing just to share briefly is, research does change policy. And it allows for practices then to do things that they wouldn't otherwise think they could do. So this is the CMS guide model. The CMS guide model came from 3 programs, one at IU, one at UCSF, and I'm blanking on the third one at the moment. But 3 programs, David Rubin's at UCLA, that all showed effectiveness in improving care and worked with CMS for a period of years to come up with a capitated payment model so that hospices, that community agencies, that health systems can now implement to address care. And these many of them are now up and running. We had a tranche that launched in 24, a tranche that launched in 25 around the country to identify caregivers and then meet the needs of the caregivers and supporting them in the care they're providing to the person living with dementia. It includes a respite option too. Many hospices have picked this up. So, research does lead to policy, leads to practice, and you have to do intentful things all along the way. Otherwise, if those researchers hadn't gone to CMS, would this model exist? I don't know. If they hadn't done their research in a way that could be done in the real world, could they have even gone to CMS? Probably not. And so thinking about those in every step along the way. And so what we need is more research and innovation in the settings where persons living with dementia are dying, in partnership with where earlier on in the trajectory, persons living with dementia or cognitive impairment, with caregivers, with clinicians and settings to make those changes. It can't be a one-way street. It has to be bi-directional. And we have a lot of opportunities for how we now get there. So as Dr. Shippey mentioned at the beginning, we now have the Ascent Consortium. We just closed our first LOI round for both pilot studies and research career development awards. But this is geared around palliative care across the lifespan to advance the evidence and advance evidence into practice in serious illness. So while we're talking about dementia today, we are across the lifespan. Everyone from neonates to persons living with dementia and older adults are included within this program. One of the other things that we're starting to move forward as a first project, it's not totally approved, but I'll share as just a snippet, is how do we help provider organizations to move evidence into practice faster and accelerate that transition. So that's one of the other things that we've been tasked with working on. So it's not just about hardcore research, and we've been developing partnerships across the country. If you're at a healthcare organization and you're interested in learning more about partnering with researchers, please feel free to reach out to me and I can connect you with our consortium in that way. And then we also similarly have the Impact Collaboratory, which is focused specifically on persons living with dementia and their care partners. We have 2 calls open for interventions that have efficacy already shown and are interested in moving those into the real world kind of what are called pragmatic trials. We have 2 LOI opportunities that are open right now. So please go to our website, take a look. And there is a webinar actually, I think at 1 o'clock today, 12 o'clock Central Time, where we'll be going through the pilot mechanism, and then I'll be doing the demonstration project mechanism next week. And we've also got a bunch of other things. The Roybal Network, which is developing behavioral interventions. There's one at University of Minnesota, the Embrace. There's also one that's focused on end of life that is between Yale and USC, amongst 10 others. You can see all the Roybals. They just closed their annual evaluation. There's the AI centers that NIA has. They're refunding them over the next period, but this will be another opportunity. There's the Hillman Foundation. So they have serious illness and end of life innovation awards. And these often also go to practice settings, not just to researchers if you have an innovative idea. So we can get there, but we need researchers, practices, persons living with dementia, and caregivers to work together in doing that. So with that, Tatiana, I'll hand it back to you, and thank you.
Thank you so much, Dr. Brody. That was a powerful and a highly insightful presentation. And I really, really appreciate that we have a chance to host you here at CHAI. Now, for our participants, if you have questions for Dr. Brody, please go ahead and put them in the Q&A. We are going to start the discussion after we introduce the panelists. And with that, I would like to introduce the moderator for our session today, Dr. Zach Baker. Dr. Baker is a valued member of CHAI Research Corps who always actively contributes, and we really appreciate your participation, Dr. Baker. He's also an assistant professor at the Edson College of Nursing and Health Innovation at the Arizona State University. His research focuses on developing and evaluating technical tools and psychosocial resources that help caregivers and persons with dementia to thrive, a mission that I know he carries throughout his work, which supports dementia caregivers, and that also involves a community advisory board that works with him on this topic. Zach, we are really grateful to have you here, and I'm going to hand it off to you. Thank you.
Thank you, Tatiana. And thanks, Ab. That was a great presentation. I've been following Dr. Brody's work for quite a few years, and the fact that I'm still taking notes while he's talking is probably an indicator that there's a lot of cool information in there. As far as physical description goes, white man, brown hair, blue eyes, white shirt, and when I wrote the script, I wasn't sure what sweater I was going to wear, but it is currently a navy blue sweater. Thrilled to welcome three really exciting panelists today. Some folks I've known for quite a while now, and some folks who I'm just getting to meet in this process. So to begin our discussion, we'd like to give each panelist a moment. They're going to be able to introduce themselves. I'll also give them a brief introduction, share insights about their current work, and maybe reflect briefly on the importance of the topic to their practice. And again, please feel free to throw those Q&A questions in there. We have some prepared, but I'll definitely lean towards yours if you want to throw them up. So first, please welcome Christina Wright-Peterson. Christina is an accomplished nonprofit leader and healthcare advocate who serves as the executive director of the Minnesota Network of Hospice and Palliative Care. As the former founder of Red Drop Resources, a nonprofit supporting blood cancer patients and their families, she blends clinical insight with strategic leadership to strengthen compassionate care through statewide advocacy, education, and collaboration. Christina, I'll turn the floor over to you for a couple minutes if you just want to fill us in on who you are and any thoughts you might have.
Yeah, thanks so much. For physical description, I am a white woman with brown hair wearing a brown sweatshirt or brown sweater today. My background is in nursing. I started off working in inpatient psychiatry and eventually found myself in hospice nursing. That's what drew me to this line of work. But I originally got into this, even into nursing, because of my own experience with my father being diagnosed with leukemia when I was 9. And we cared for him for 8 months at home before he passed away. And so that's really been my fuel to ensure that everyone has access to live and die as they want to, which is conveniently the mission of MNHPC. So we work to ensure that providers that are giving the care, as well as the community, has access to education related to serious illness and end of life. And then we also do advocacy work to ensure that the legislators and those that are making decisions are well informed of what our needs are. I just have 2 really quick takeaways. There was a lot of takeaways from Dr. Brody's presentation, but 2 that I think are really important to call out is the mission moment and how communication challenges with those facing dementia at end of life has a drastic impact on the care that they receive. And so having training available to the caregivers, both professionally and personally, is really critical, because we hear that frequently, that is a large hurdle for all of them. The other thing I want to point out is that we do see a lot of those non-pharmaceutical interventions. That music therapy example was perfect. I actually went to college the first time around to be a music therapist, so thank you for the call out to a great field. But what's important to recognize is music therapy, massage therapy, chaplaincy, all of those non-pharmaceutical interventions that palliative medicine and hospice care are really great at are not reimbursable. So when we think about advocacy and policy work, we really need to have a recognition that those non-pharmaceutical interventions need the same value placed on them, because what's happening is they're the first that providers are considering needing to discontinue. Thank you.
Thank you. Next, we're pleased to introduce Rachel Bialystowski.
Well done. Yeah.
Okay, yeah, whose name used to be pronounced differently, but I've tried a bunch of pronunciations, and she said that one was
That's
good
great.
to go with. Rachel's a licensed clinical social worker with a decade of experience in palliative care across both hospice and hospital and clinical settings. She specializes in helping people cope with serious illness like cancer or heart disease, navigating end-of-life care, and processing grief. She believes in the wonder of the human journey of loss, growth, and connection. Rachel, please.
Hi. And again, Dr. Baker, well done. I said it took me several dates with my now husband before I could pronounce the last name Bialystowski. So I'm so honored and thrilled to be here with everybody today. I've been in this work really for most of my social work career. I worked in a nursing home for quite some time and just so appreciated your acknowledgement, Dr. Brody, of the need for support for caregivers, both like personal, but also professional caregivers, and the impact that demoralization, I think, and apathy can have on the care that's provided to people. Following my nursing home work, I worked for almost a decade in the field of palliative care. I was an inpatient palliative care social worker for some time, and then I switched healthcare systems so that I could provide inpatient healthcare or inpatient counseling as well as counseling in a clinic setting where I would see patients. I would also sometimes just work individually with caregivers. A line I would use very frequently with folks at bedside was, I said, if we're not supporting you, we're not supporting your loved one. This is an issue of supporting a system, not just supporting the person who has come, to the hospital for care. And yes, again, just recognizing what Christina shared just about, I have witnessed it over and over in different healthcare settings, that the holistic non-pharmacologic interventions that are available to people that we know help are often the first ones to be cut. I'm still in contact with colleagues who are chaplains, social workers, and still in the medical field, and they are like, we're just waiting, because it is so much easier to prove that you fixed something, especially with a reimbursable intervention. It is so much easier to prove you did that than to show that you prevented something. I believe in my heart of hearts that when palliative care and hospice are provided appropriately and with care and well-funded, I said, I believe in my heart of hearts that we're preventing the development of stress disorders for caregivers down the line. But it's very, very, very difficult to prove that. If anybody has a way to research that so we can prove it, I would be so on board. And I think as a clinical provider, as somebody who's like the person kind of on the ground and supporting patients and families, I love this work very much, because I think it is very, very powerful to kind of go in and just sit with people and kind of say, what do you feel like you need right now? What are you worried about? I can't always tell you what to expect, but I can tell you, that we can provide care, and just providing care and support. I believe it goes a long way in helping to, prevent or stave off complicated grief, PTSD. I believe that right from the macro to the micro, this work is so important, and it needs to be focused on, as you touched on in your presentation, Dr. Brody, again, connection and humanity, and how do we find the humanity in those numbers. So thank you so much, everyone.
Thank you. And finally, excuse me, I'm going to sneeze, I think. Nope, gone. Okay, and finally, we are honored to have Jessica Hausauer, PhD. Jessica works as the CEO for the National Coalition of Hospice and Palliative Care, where she works with members to advance national policy priorities in serious illness care across the lifespan. In this capacity, she leads efforts to advance the clinical practice guidelines for quality palliative care and represents the coalition on national bodies like the National Academies of Sciences, Engineering, and Medicine's Roundtable on Quality Care for People with Serious Illness. Jess, please.
Great. Hi, everyone. It's great to be here. My physical description is I'm a white woman with green eyes, red hair, and wearing a blue dress. And as Zach said, I lead the National Coalition for Hospice and Palliative Care. We advocate for policies and practices to provide the best care possible for people living with serious illness and at end of life. We do that by bringing together our members who represent leading national organizations, trade associations, professional member groups, organizations focused on research, as well as consumer advocacy groups like the American Cancer Society. So we come together. We really see ourselves as a quality steward, maintaining the clinical practice guidelines for quality palliative care, as well as a consensus to action bridge, where we work together as a field to develop consensus and then turn those into policy priorities. The connection that I make here with Ab's presentation is just, again, to reiterate the need to continue to build our evidence base and to invest in that research. So one of the things the coalition helped do and was instrumental along with our members was securing the $66 million over 5 years for the Consortium for Palliative Care Research Across the Lifespan, which now has established the ASCENT consortium. We also have been successful in securing appropriations funding for palliative care research. So back in 2024, we got 12.5 million for palliative care research, which was continued through 2025, and we continue to advocate for additional research appropriations. So we've been, really happy to see success in being able to secure those investments, but we need a lot more. When you look at the NIH budget, it's less than 1% goes to palliative care research as compared to other areas which get considerably more funding. And so the more that we can do to work through or partners to continue to build that evidence base is critical. And then we need to bring that evidence into education settings. And so that goes for healthcare professional curriculum programs, right? Like we need core education as doctors, nurses, social workers, chaplains are receiving their training. But then once they're in practice, we also need to be bringing that into continuing education settings as well.
Thank you. So as I mentioned, feel free to keep those Q&A questions coming, and I will prioritize them over our pre-prepared questions because you're here, so why not? The first question is largely related to communication. And so the participant asked about best practices for recognizing when someone with dementia is transitioning to that end of life phase when communication is limited. And then they kind of have a secondary piece here about approaching symptom management, things like pain or agitation when there's a lack of verbalization. I know, Ab, you mentioned in your presentation that it's hard for us to say when these kind of these key 6 months are happening. So I'm curious if people have recommendations around best practices there.
Yeah, 6 months in general, I think, is a challenge, right? Even our prognostic indicators are only right like 70-ish% of the time, which means they're wrong at least 30% of the time. So, there are the CMS not CMS, but the Medicare contractors who kind of say our best guess is that people have are dependent on at least 3 of 6 activities of daily living, and have had a recent hospitalization, are kind of some of the main kind of factors for that 6-month prognosis. But the end of life transition piece is a different matter. When you have nonverbal individuals, you'll see folks that are either refusing or no longer able to eat or drink, is one of the first kind of things that I'll see. They'll maybe be even less responsive than they had been previously. So often persons living with dementia are still communicating, even if it's not verbally, and you'll see whatever communications they were using, whether it might be a grunt or turning a head away or a shake or what have you. as those start to decrease more and more is when you're starting to really think either there's a delirium because of some acute illness or transition, and sometimes those are one and the same depending on the goals of care. From this, sorry, the symptom question, Zach, could you repeat that piece?
Yeah, so that was specifically when there are challenges in communication. How do you approach symptom management, things like pain or agitation, when the capacity for the individual to verbalize that is not really present?
I used to use the pain ad. I am no longer a fan for pain of using the pain ad because I don't find that it actually works that well in community settings. In nursing homes, it's okay. So if we're talking about pain and other symptoms that a person living with dementia might experience, I'm looking for changes from their baseline, or if they're looking at the underlying causes of something. So let's say a person all of a sudden experiences agitation. Well, what's the underlying cause of that agitation? Is it because they don't know who you are and you just walk up to them and are trying to give them a bath without them recognizing it? Or is it because every time you move their hand, they have arthritis and they're in pain, right? And so I think there's no simple tip or trick. It all has to get down to what's the unmet need that causes a particular reaction or behavioral symptom that they are experiencing, that I then find we have to go through a checklist of potential things that could be causing that need. And there's a great algorithm that we teach in our program, which is called PIECES. It's physical, intellectual, emotional capabilities, PIEC, environmental, and social. And so those 5 things, you have to go through a checklist of those 5 things to really think through what is the underlying need of a symptom, versus just trying to treat it with something, because you have to treat the underlying mechanism, not the expression of the symptom itself. Agitation can mean 100 different things, from I'm hungry to I'm in pain to I need to be changed, etc. So it really is the underlying need that I think is most important to look for. I see Christina and Jessica shaking heads, but I don't know if you, and Rachel, I don't know if you guys have any other pearls.
No, well, it just brings to mind a patient that I cared for quite some time ago who, I mean, the long story short is he was profoundly agitated. The staff were freaking out. Palliative care got called in, and I went in with the nurse practitioner and asked, has anybody done a bladder scan? Like, it was one of those few, I sometimes say to people, I was like, I know the street signs, but I don't know the whole map as a social worker. But I said, does he need to go to the bathroom? And they did a bladder scan, and that's what it was. He was sitting right in insane discomfort from just like needing relief from having his bladder emptied. So they placed a catheter and the symptoms resolved. It takes time, right? It takes so much more time to figure out what is the underlying cause of this than it does to just throw something at the symptom itself, which again is why I believe palliative care is so important, but also just adequate staffing, adequate, well-supported staff, which is, I just feel sad because that feels like such a pie in the sky thing to be aiming for. But again, it just, right, it takes time and energy. It takes human assessment to get to that, what is underlying this, and how do we care for a person and their caregivers.
Yeah, I just wanted to echo that making the differentiation between terminal decline and functional decline is probably one of the biggest challenges for end-of-life care with somebody experiencing dementia. So we do a lot of, or those on the field do a lot of, kind of trialing things and seeing what the response is. If we, like the bladder scan, that's a perfect example. Do they want assistance getting up and walking? We just try to do all of those things. And what we're looking for is a trend of decline. So are they sleeping more? Are they eating less? Are they engaging less, even in the ways that they were engaging? I also just want to take this as an opportunity that this is where advanced care planning comes into play, that once somebody has lost their ability to communicate, it's harder for us to know what they do want us to do, how much do they want us to explore, how many interventions do they want us to try. And so when we have advanced care planning that says, when I'm no longer able to speak or express my needs, this is what I want you to do, that's an extremely helpful tool for caregivers, both personally and professionally.
And I also, oh, sorry, I just want to echo that. Another thing that I frequently say to people is the conversation that happens as you're completing that healthcare directive with your loved ones is, a document is no substitute for those conversations. Like ideally, we've had both. But I tell people, if you have to choose the conversation or the document, I usually say, let's go for the conversation with the caregivers and with the loved one.
Kind of want to take a step back for a second, and the words palliative and hospice have come up several times today, and I was wondering if we could just if somebody would be willing to step in to say, okay, here's kind of some major distinctions and potentially even some misunderstandings that you see from people on a regular basis. Jess, do you mind if I throw that one at you first to
Sure,
distinguish?
yeah, I'll take a stab and then others can join. So there are some key differences between palliative care and hospice around a few key things. So one is around when you can get palliative care. So palliative care you can actually receive right away. You could get it at the time of diagnosis, as opposed to hospice where you have to be determined to have 6 months or less to live. And people don't always recognize that you can get palliative care earlier on in your illness diagnosis. Another distinction is that you can receive curative treatment when you're receiving palliative care. Cancer is an easier one maybe than dementia for this one to kind of connect to, but people don't always realize that. Whereas for hospice, to go onto hospice, you're generally at a point where you're no longer seeking a cure for your disease. And then when it comes to payment, so on the practical side of things, the main distinction between palliative care and hospice is that we have a hospice Medicare benefit, which sets eligibility and comprehensive, standardized processes to provide payment for hospice. We don't have the same thing for palliative care. So palliative care is a lot more variable, and that lack of a standardized payment creates more barriers in terms of accessing palliative care in some cases.
Building on that, does anybody have any? Oh yeah, Rachel, please.
I just wanted to say another thing about palliative care that I like for people to know is it is okay, as Jessica said, to get a palliative care consult early in an illness. You do not have to be having a symptom crisis in order to consult with palliative care. In fact, a palliative care team would much rather meet with a person when they are able to engage, right? Able to talk about what feels meaningful and important. You have some rapport built up so that if there are symptoms to manage later on, you're not building rapport and coming up right with a plan where you're exactly doing what we talked about, figuring out what's causing the symptoms, figuring out how to manage the symptoms. Yeah, I remember I gave a presentation some time ago for a serious illness group, and people kept saying, when can I make a consult? And I said, now you can meet with somebody tomorrow. You do not have to be in crisis to meet with a palliative care provider. You also don't have to be in crisis to meet with a therapist. I'm just going to put that out there too.
I'll ask you to stay unmuted then, because that's a kind of perfect transition to what I was going to ask, and really about talking to the care team. So building this rapport, getting the conversation started with the care teams. What's some of the content we should have in those conversations? Kind of things should I ask?
And something that I often say to when I'm meeting with folks who have been referred to me for support with coping with serious illness, and I will fully acknowledge that I'm biased. I'll say, I did palliative care for a long time, so I'm biased, but are you working with a palliative care provider? And people will sometimes say, my provider hasn't brought that up. My oncologist hasn't brought that up, my primary. And I say, there's a very good chance they haven't brought it up because they're afraid they'll lose their rapport with you, because they are afraid that you will have the response of, oh my God, why do you think I need palliative care? Do you think I'm dying? So I think Just starting, right, like if you're a medical provider and you're kind of doing this early content conversation, I mean, I would even just start with saying, like, we don't need to make a referral today, but I would encourage you to think about a palliative care consult earlier rather than later, and this is why. You don't have to be at end of life. You don't have to be in a crisis. And it doesn't mean it might, like talking with people who are living with cancer or right, like something of that nature. It doesn't even necessarily mean that like the cancer isn't curative. As Jessica said, you can be receiving treatment, aggressive treatment while on palliative care, while receiving palliative care. So I think in those early conversations, I think there's a lot more bandwidth for, I forget who said, right, like you're looking for a trend. You kind of put something out there, then you see how it goes. Bring up palliative care and see how they respond, right? Does it seem like they have the capacity to tolerate thinking about something that they haven't, that they maybe didn't know they were going to talk about? And then that's actually, I think, a much better space for exploring and just giving some information. It is different from hospice. We can enroll palliative care at very different stages. This does not necessarily mean that we're in crisis now. Christina, I see you nodding. I would love to hear what you have to, if that resonates or brings anything forward for you.
Yeah, I think if you asked anybody who works in hospice or palliative care in the state of Minnesota right now what their one wish would be, it would be that people would engage with them sooner. And so doing that allows us to create a plan and get to know you as an individual and your care, your support system, which is really great. The other thing I want to point out about palliative medicine that I didn't have a full understanding of until I was working on a medical oncology floor and got to interact with the palliative teams. They're interdisciplinary, just like hospice. So it's not just a physician or a nurse practitioner. You're going to engage with a social worker. They have, integrative medicine as well. And so that is really the unique type of care that you're getting with both of these, is that you're not just going to be getting care from one person or one discipline, which is a huge strength.
I will say one thing just to think about within the palliative care sphere is, and this does hold similar to hospice, dementia has not typically been within the sphere of many palliative care teams and providers, other than goal clarification, because that's a much more competency element of palliative care programs, but across from a medical and nursing perspective, palliative care is still in its growing and evolving stage of around some of these illnesses that are not cancer, and in this case dementia specifically, where geriatrics and geriatricians may actually in some cases be the better alignment. And so it's also understanding where a particular team is at. We just had Laura Hansen, Dr. Hansen from University of North Carolina finish what is probably the first multi-site trial of a dementia intervention for inpatient palliative care teams. So we're still at the fairly early stages, even though a lot of palliative care providers are also geriatrics trained. So I'm a geriatric and a palliative nurse practitioner. There are integrative specialties where physicians go through geriatrics and palliative care, but it is not one-to-one. And so just knowing the strengths of your team. So for instance, at NYU, the geriatrics team sees all the persons living with dementia across this, wherever they might be across their lifespan. Part of that is for workload reasons, and part of that is because the geriatrics team has the specialization specifically in dementia, whereas the social worker on the palliative care team does provide, the support is slightly different for a caregiver of a person living with dementia than it is for a person with cancer or liver disease or what have you. But many of the same social supports are similar, and needs around how to actualize caregiving and how to address it when you're also caring for your child and caring for, and working 40 hours a week. And those things do not change. And so there is, while the particular needs of persons living with dementia does change the feel of caregiving, um, a lot of those elements are much more transferable than some of the disease specific issues around how do you care for behavioral symptoms.
Yeah, just to build on that, that was what was coming to mind for me as something to emphasize, particularly for dementia and thinking about the value of palliative care or hospice, is that part of the philosophy of palliative care and hospice is that the family is part of the care unit. And so it's really being able to provide care for the patient, but also for the family members, the caregivers, the care partners. That's just something that's really important for people to think about when they think about accessing these services and what they can get. And then in terms of questions to ask, things are going to, be different priorities for different people, but just some things to kind of think about if you were to be engaging with a hospice. You might want to ask about availability on nights and weekends, right? So everyone is required to have access to 24/7 care, but make sure, like if you were going to need someone to come out physically to your home, make sure that that program can offer that if that's important to you. You would also want to ask about perhaps, what kind of contracts the hospice has with local nursing homes or assisted living facilities, if you think there's a possibility that there might need to be a transition at some point. And then one of the things I think that comes up for people, hospice is really wonderful. We have great outcomes, but where I think sometimes people get caught off guard is if when in realizing that they actually, as a caregiver, are going to provide a lot of hands-on care. You're not going to have someone in your home 24/7 with you. And so just having that awareness of that is important. And then I think another piece, particularly with dementia, is having some clarity around eating and drinking at end of life and how that might change and how the needs might change. And as a caregiver, often that's one of the things that we pay attention to the most, right? With our loved one, are you eating, are you drinking? And those things change in that transition time. And for people to be aware of that is really important, and to ask those questions early on so you're not caught off guard.
For the next question, I want to give you the magical power to change something about policy with the snap of your fingers, right? You've talked about how extensive efforts have raised the capacity to do research in this space. Have you talked about a bunch of things that you've done to actually change the way care is being delivered? We've talked about maybe some desire for change for palliative being reimbursed in a very different way from hospice. So if I give each of you the power to change one thing and somewhere in the policy space, what do you pick? And maybe Jess, we'll go back the other way and I'll start with you.
Sure. Okay. I can't pick one, so I'm gonna pick two. One is we need to pass PCHETA. It's the Palliative Care and Hospice Education and Training Act. This is a workforce bill. It's very similar to the Geriatric Workforce Enhancement Program. In fact, the legislation is built off of that same model of legislation. So this would be legislation that would provide potentially authorized $20 million a year for 5 years for education programs to be set up around the country to provide education, awareness, and research. We need to get that bill passed. Currently, Tina Smith is a co-sponsor, but we need to continue to work here in Minnesota on our federal representatives to get them on board with PCHETA. So that needs to happen. And then with the coalition, another priority that we have that's a little bit more future thinking in terms of how can we evolve would be, we want to first protect the Medicare hospice benefit, but we also want to improve it. And so Ab mentioned this, one of the things that there's some conversation around is looking at that eligibility criteria, that 6 months or less, and is there a way that we could broaden that out? And in particular, that would help with dementia patients probably more than some other patient populations. So those are some of the things that in the policy space at the federal level that are kind of high priority. And then here in the state, so I chair the Minnesota Palliative Care Advisory Council. We have been actively working to secure palliative care reimbursement to create a benefit through medical assistance. And so that would be the state priority.
We'll snake back through, so we'll send it to you next step.
I'll leave some of my more controversial ideas out of this and focus on the palliative specific ones for today. I think the one thing I would do is concurrent care. So right now in the United States, only children can receive concurrent hospice and curative care at the same time. Whereas older adults, and this particularly affects persons living with dementia, cannot. There is a time limit and there is um, a limit as to what types of care are received, which it's not really patient-centered. The way hospice was originally passed through Congress was by saying it will be revenue neutral or actually saving money, and hospice does save the health system money. It's one of the few bright lights in doing so across our particularly egregiously productive health system in terms of how much we spend versus how much we get out but of it from a health perspective. But I think that this idea that if we're able to provide care, hospice care or palliative care across the board when people need it, that it is not just people who forego curative treatments and that it is not just for the last 6 months of life, that we will seriously advance the way we are providing care to seriously ill individuals. It's a false dichotomy, and it's something that shouldn't exist. Even if for dementia, we don't have any life-sustaining, reversing treatments at the moment, but we're not far off, I think, with the tau drugs that are in the pathway at the moment.
Christine?
Those were really good ones. So I'll second both of those from Jessica and Dr. Brody. One thing I would change is Medicare currently sets the per diem rate for hospice care across the country, and they do that by county. And one of the ways that they inform what is paid is based on cost of living in that county. What that results in is rural communities have a lower reimbursement rate because they have lower costs of living. However, it costs more money to take good care of those communities. And so if I could change one thing, it would be for Medicare to provide a reimbursement rate that would make care in the rural communities feasible and sustainable for providers.
And Rachel?
Feel more out of my element here doing direct practice, but again, just echoing what Christina said. I remember when I was a nursing home social worker, I was very aware that like the nursing home where I worked received different reimbursement than the nursing homes in the same system up the street, because of an algorithm that had been run 20 years prior. And so I guess I think I'm pretty basic. I want everybody to have access to affordable health care, and I want that health care to cover palliative care. And while this might sound self-serving, I want to be able to see people to provide clinical, non-medical support, and I want to be able to, be reimbursed for that at a fair rate. And I don't want to have to give people a diagnosis of major depressive disorder or anxiety disorder or something of that nature in order for them to receive care. I want it to be, you have a loved one living with a serious illness, or you yourself are living with a serious illness that qualifies you for extra emotional support that we do not have to pathologize by fitting into a DSM-5 category.
I like that. The next question actually comes from someone. So for anybody who's not familiar, I do a lot of bereaved dementia caregiver research, and probably one of the first people to talk to me about bereaved dementia caregivers is the one who offered this next question. So from Tamara, someone mentioned differentiating between terminal decline and functional decline in the dementia context. Can you please explain how you'd suggest explaining this differentiation to your clients or patients who are often wondering what might be going on?
Oh, wow. Okay, so I think on a very high level for caregivers or patients, we know that as our body shuts down, as our body begins to die, certain organs and certain systems begin to turn themselves off. And so then we see symptoms of those systems beginning to no longer function. When we are talking about terminal decline, this is often related to our brain no longer being able to communicate appropriately with our body to tell our body what it should be doing, but our body can still do it. The systems haven't all shut down yet. And so it often looks like, again, those trends. It doesn't come and go per the day, per the time of the day, per the environment. When we are seeing terminal decline, it is generally consistent, and functional decline can be impacted by environment or other factors.
Thank you. Another question that came up, which taps on some of the things we talked about earlier, is specifically thinking about how much longer people have. So how long someone might last because of hand feeding, how long until they lose their ability to swallow, who prepares, or how should family members and CNAs be prepared to witness this too? So first piece being, do we have an idea of when some of these things arise, what the timeline looks like? And second piece being, how do you get people prepped for what they're going?
Yeah, so the feeding is one of the things that is the most distressing for family members and caregivers. And there's a couple of things that I always try and pose it as. One, the evidence shows that tube feeding does not prolong life any more than hand feeding does. And there's a couple reasons behind that. People who are tube fed are more likely to aspirate, so then the food is likely to go into their lungs and cause them to have a pneumonia and pass away from that sometimes sooner, sometimes not. This is different than other conditions. This is only dementia specific that I'm referring to. Hand feeding has been shown to be highly effective, and it is also an opportunity for a positive aspect of caregiving. And so I really, in nursing homes, it can be a little more challenging because of staffing constraints. But it can be an opportunity to really connect with the person that they're caring for and is effective. And we know that. And if you're hand feeding the right type of food that's, been that goes along with their swallowing capabilities, and they're eating sitting up at 90 degrees, that is the reason that someone is going to pass away is not from poor nutrition. You can get aspiration even if you do hand feeding, but it's less likely because they're also sitting up when they're doing this, versus when peg tubes happen, people often are lying in a bed, even if the head of the bed is up a little bit. It can go too fast for their digestive systems. And then the other piece of this, because activity is declining, and metabolism declines generally in older adults and even more in persons living with dementia. So what you might think is enough food or not enough food is not necessarily matched with caloric needs of the patient. And so I tend to focus on those things. And if someone is really concerned, I usually end up with my favorite answer, as long as they don't have diabetes, which is ice cream diet, which no one doesn't like eating ice cream for them. There are a few people, but that I've run into, but we can go through ice cream diet and just liberalize the diet and find things that work. And so while it's a big concern for caregivers, whether paid or unprofessional, it's actually amongst the more easily answered things, rather than the unmet needs of, leading to agitation, et cetera.
I have a couple of community partners who they're really like my first community partners that I ever developed up there in Minnesota. And they talk about when they were taking care of the wife's mom. She had dementia and was largely bound to her recliner towards the end of life. And they were feeding her, I think it was like Ensure shakes or something like that, but she referred to them as her milkshakes, and it was a high quality of life thing, and it was supplying necessary calories. Yeah. For any of those people who don't like ice cream, maybe that's a alternative. There's a question here about managing tensions between maybe a desire for more of the healthcare system for things that are going to maintain life, continuing this topic of feeding, and specifically contrasting that with someone who has expressed advanced care preferences, where They want comfort care. They don't want these things that are going to unnecessarily extend life. Advice for navigating that tension.
I would say that was a huge thing that we were called in for as a palliative care team in a hospital setting. I think it was, I honestly, I cannot think of a situation where I had a provider, like one medical provider who was like, family doesn't want a feeding tube, but like hell or high water, I want to have it placed. I think the tension was often more if one family member wanted to pursue that intervention and another didn't, or if a doctor is having a conversation, a nurse practitioner is having a conversation, and they say, well, we could do a feeding tube. And the family says, yes, that is what we want. And then another thing that I said a lot in palliative care was I said, it's not really our job to talk people out of taking an intervention that was offered to them. So I think number one, just education for providers about how to navigate this. And then also like we would go in and we would talk with families, and it just takes time. It takes time and rapport building and like spending time with the family and the patient and coming to a goal, coming to a decision that is in alignment with what the family what the family's hoping for, what the patient is hoping for. So I would see it happen as a palliative care social worker that, we'd go in and say, we heard that you said you wanted a feeding tube. And they're like, well, that's what the doctor said we should do. And when you would tease it apart and kind of like sit with it and sit with the nuance of the situation, you really were able to come up with a different plan of care. But it takes time. It takes time. Yeah. Time and energy.
And it shouldn't be offered in the first place is the first piece of that. But
Yeah, that's
I think one of the things that happens sometimes, food has such meaning in our society, and reminding people that a feeding tube is not food. It's liquid nutrients being pushed into someone's, stomach to meet caloric needs is not feeding and eating in the social aspect of that. And that hand feeding is effective as part of this. I think the other piece is what is the goal, right? Because we know as soon as a person has a feeding tube, that feeding tube is going to get displaced, and they're going to end up back in the emergency room and back in IR getting it put back in. They're more likely to have infections and therefore end up back in the hospital. And so I try and not frame it around the decision around the feeding tube itself, but around the goals that the patient has previously stated, because that helps to serve as a clarifying, both ethically and legally. If a patient has said they didn't want something and then the caregiver overrides it, actually our job is to perform an ethics consult and to not perform what the caregiver has stated if it's been expressly stated that they don't want something and now can't speak for themselves, and then B, really to what end? So I ask, what do you envision as, under the circumstances, what would be the ideal outcome for you for where we are? And then I can walk them through ideal versus realistic. There was sometimes, especially more in surgical decisions, there's a great tool called Best Case, Worst Case that was developed by Gretchen Schwarzy in Wisconsin. It's next state over, right? Sorry, geography. Yeah, next state over, and then Toby Campbell, who's expanded that to other settings as well, also from Wisconsin. And so I'll often talk about, well, the best case of doing X is this. The worst case is Y, and the most likely case is this. And it has a really powerful effect on helping people to think through the intentionality of what they're asking for and what they can expect to see. And often, I've seen this before hip surgeries, for instance, where we do best case, worst case, and they'll say, oh, since they can't do rehab and, well, I do want to do it because palliatively it will help them with their pain in the best case, or, oh, they're not going to be walking again. Well, that was what was really important to them about this surgery. So I don't really want to do this because they were already pretty wheelchair bound and can't really participate effectively in physical therapy at an intense enough level to regain that function. So those things often help with goals clarification as well by sharing like what could the outcomes look like and painting that picture, which we often don't do well in the healthcare setting.
I know that we're very short on time, but another thing that I just wanted to bring forward is I think most of like the examples that I've given, these conversations are all being held with people who have moderate to high trust in the medical system and moderate to high trust that the recommendations made by a medical provider are in their best interest. And just putting out there that there are lots of people with whom you could have this conversation. It could be received very differently because they have very good reason to believe that the healthcare system does not have their best interests at heart. If we could do a whole other, we could talk for a whole other hour, I think, about that. But I do think it's just very important to always be remembering that the lens through which I interact with the healthcare system, which is, that my providers have my best interest at heart, might not be the same framework that other people are viewing their experience through.
So putting myself in the shoes of an attendee from this meeting who maybe, this area wasn't their primary focus already. They're talking to a friend who gives care to a person with dementia. They're saying, hey, there's a bunch of end of life and bereavement stuff that's coming up. And that caregiver is open to learning, says, okay, I want to get myself prepared for this. Assuming they can't call upon you, and assuming maybe this recording hasn't been posted yet, what's the resource you send them to? Where do you tell them to go look to help them prepare for the end of life and bereavement experience that they're probably going to have?
Okay, well, I'll do a shameless plug for resources like MNHPC. This is part of our role, is to have those resources available and answer those questions. So at a state level, they can contact us. The other thing I would say is that a Medicare requirement for any hospice agency that is contracted with a skilled nursing facility, so in a nursing home, is they have to provide education to their caregivers. So the hospice agency needs to provide end-of-life education to the skilled nursing facility staff. So if I were a staff person, maybe at a skilled nursing facility, I'd be saying, who are my contracted hospice providers? And I need to talk to them and get some education on what this is going to look like.
I'll just echo, because I was going to give in the plug for MNHPC for here in Minnesota, that's a go-to resource, but also the resource, Ab, that you shared earlier, your collaboration with MPHI and CAPC, the Dementia Care Toolkit, is a good one that, is built from the perspective of folks working in end of life. And as we close, I do just really want to emphasize that to everybody deserves access to specialty end of life care. And so we need to do everything we can to increase that access. But hospice and palliative care can't do it alone. We need other healthcare professionals to be trained in basic primary palliative care skills and know how to have conversations and know when to refer. And to your question, Zach, as a public, we need to be prepared. We need to have thought about these things throughout our lives so that we're not doing it for the first time when we're really sick or when we're dying or when we're in a crisis. And so, again, the resource question is really good, and MNHPC, and there's organizations and advocacy groups like the Minnesota Palliative Care Advisory Council that people can go to get connected and involved.
I also tell folks that you can have an informational meeting with a hospice program, and it does not mean that you're enrolling. They can simply come out and meet with you and talk about what hospice is and what some indicators might be when it would be appropriate to enroll. And then, you've built a little bit of rapport. And so that's another resource that I often direct folks to after MNHPC, of course, or alongside.
Okay, well, thank you. I can see Tatiana's back on video here, so I think I'm going to pass it back over to you, Dr. Shipp.
No, this was wonderful. And I know we can go for another hour here or more probably, but I want to be respectful of everyone's time. Thank you so much to everyone for joining us today. Really appreciate your time, participation, and I hope this was a valuable use of your time. I want to give a special thank you to our incredible presenters, Drs. A. Brody, of course, but also our panelists, Christina Wright-Peterson, Rachel Bialostowski, and Dr. Jessica Hauser, for sharing their expertise and insights with us. And many thanks to you, Zach, as a skilled moderator today, for leading such a productive conversation and also incorporating your own expertise and experience in this field. So for the participants, a couple of notes. We will be sending out a follow-up email with a list of resources, some of which were mentioned today, a link to the recording, which feel free to share that with your networks, and also contact information for all of our speakers. Additionally, you will receive a satisfaction survey from us. We really do hope that you will fill it out because your feedback is really important for us as we continue to improve our webinars and better serve our community. And with that, thank you so much, everybody, again, and have a wonderful day. Take care.